my pleasure and honor to invite Dr. Professor Domenico LEPORE. He's going to be talking to us about understanding the pathophysiology of ROP with new insights in biomarkers. For everyone.
Thank you, Anand, for the invitation, and thank you to be here. It's a very early morning session, and see some people interested in ROP is always a pleasure. I'm going back to the science behind the use of the anti-VEGF in the ROP. So these are my disclosure as I'm a consultant of Bayer for the Firefly study, and I'm involved in the board of the HICON instruments. The genesis of blood vessels is based on two principal mechanisms. One is the angiogenesis, and the other one is vasculogenesis. They are completely different. Vasculogenesis happens in the very early, around 20 weeks of gestational age, around the optic nerve, and it is not the one that we see during our clinical work. While we see the vasculogenesis with the angiogenesis, which is a different process. Basically is a sprouting of the already existing vessels, and is driven by VEGF. There are a lot of actors playing this game in the field, and we know for sure the VEGF, but also we have other factors like PDGF-beta and TGF-1 and angio-1, which are involved in this differentiation and stabilization of the vessels. And angiotensin II, which is the one that is involved in the sprouting of the already existing vessels. All these factors are potential target for therapy of retinopathy of prematurity. We use anti-VEGF because we know the VEGF since a lot of time, and we know a lot about the story of the VEGF, and we can consider them as a VEGF-1 is a family of VEGF. The most important things you have to keep in your mind is there are VEGF with a low weight, which have no binding of capacity for heparin, which means they are soluble and they go spread around. And while other with a higher weight, they stay in the place, and they are responsible for creating a gradient inside the retina. And this is a schema that is very useful. This is done by Jane Rakesh in Boston. You see that if there is a correct concentration of the VEGF, you have a right development, and the phylopodia of the tip cells goes in the right direction. If there is a lot of soluble VEGF, we lose the polarization, and the vessels, the phylopodia comes to spread up to the retina. And if there is a ectopic VEGF, then there is a drastic loss of polarization. This means that vessels grows not only on the surface of the retina, but even in the vitreous. Given that, we have looked at the receptors of the VEGF-1 family. There are two receptors. One is responsible for the chemotaxis and self-regulation of vessels. The second one, VEGF receptor 2, is responsible for mitogenesis, and we will see that this is another important target of therapy. So going to this fantastic schema, we can act as blocking the VEGF in the intercellular space, and this is done by the drugs that we already know, bevacizumab, and then also Lucentis, Eylea, and we can also start to have some possibility to blockade the VEGF photoreceptor 2, and we will see the work done by Amy Artent. We are also another interesting option, which is blocking the tyrosine kinase cascade inside the cells. And finally, what is very promising is the use of RNA interference to block the protein through small fragment of RNA. The model of oxygen-induced retinopathy is highly representative for humans. This is very important. This model has been used by also other by oncologists and tissue engineering techniques to understand how it is feasible to let the vessels grow in a tissue. And the biphasic theory of ROP that comes from this basic science is an old one, is in place since 50s, by Arnold Patz, which was the first one to propose that ROP based on a biphasic theory. Well, the first one is vasoconstriction, where we have a loss of vessels due to relative hyperoxia, and you see here the actors that play this game are essentially the same: AGF1, VEGF, EPO, and the omega-3 fat acid. And we try to use the IGF-1 to restore the correct level of this factor, and the study that we have done failed in reducing the incidence of ROP. And the second one is the neovascularization, the one that we know very well from the clinic, and the inhibition of anti-VEGF, of the VEGF, is the technique we are using, but other, as I said, other possible options is to act with the IGF-1 and EPO. This has been translated into clinical study. ROP was the first, done by Helen Hittren in US, and then 2 international studies. One is the Rainbow. First one was the Rainbow, completed 3 years ago, and with statistical evidence that anti-VEGF seems superior to laser compared to laser for the treatment of severe ROP. And the second one is the Firefly. We don't reach the non-inferiority criteria toward the laser, but the difference is very small, and we are looking for the 5 years data that will come next year. And we can assume that we have a very powerful tool now to treat ROP. You're probably familiar with the results of the Rainbow study. It's important to just this schema, because you understand that 60% of the baby we treat are zone 2, stage 3 plus, and only 30% are related to the zone 1. And in particular, you see that AP-ROP, or the new classification AROP, is only about 13% of the baby that we treat, so it's quite rare. We only treat 3% of the babies without plus, so essentially we treat plus, which is something that we have to consider, because maybe it's probably just waiting for plus is sometimes too late. The results were here, and the superiority not matched by 0.004. This is probably due to the fact that we are very strict in defining the favorable outcome. This is the translation that the Lancet editor asked us to use, and that's why we use the criteria seem superior. Time is important to see this schema, because we understand that anti-VEGF is very fast, allowing regression in both for plus, stage 3, and even in the AP-ROP. The additional treatment is important. We know now that this is done by Brian Fleck. It's fantastic work. We treat additional who require the additional treatment. Essentially, are the AP-ROP and zone 1 ROP, and they were retreated when they reached the zone 2. So pay attention, because these are at risk for retreatment, and the retreatment rate is about 30% in the Rainbow study, and is less in the other study, in the Firefly. Just to be quick, the results you know already. Important to see that we have less high myopic eye in these babies. The results we have a difficult assessment of the peripheral retina when you only use the indirect ophthalmoscope, and again, we don't see any difference like which he pointed out in his study. Firefly is the same study, except the fact that we treat also on monolateral studies, and the favorable outcomes are almost the same compared to the laser. And again, the ophthalmic outcome at 2 years seems the same. We have to stress that we didn't have any long-term reactivation. This is important, and we have a very powerful instruments to treat ROP. We have to keep in mind that we have to be aware of the reactivation, but we didn't see any long-term reactivation at least in this study. But we need to remodel our guidelines in terms of either organization of the follow-up and probably also of the criteria that leads to treatment. Briefly about what we can do in the future. The fantastic work that Anand has done with the indirect predictors, indirect non-ophthalmic predictors is very important. We are looking for biomarkers that allow us to understand who's the baby that are at risk for reactivation. And the tear fluid inflammatory factor seems to be very promising in giving us an instrument to understand and to point out the risk of the reactivation. Our study on fluorescein angiogram seems promising, more invasive, of course, but still very, very sensitive based on the fact that we show that it's a Shansen leakage in the fluorescein angiograms done after treatment can be a factor that allow us to understand who's going to progress toward the retreatment. And again, what we have to do in terms of theoretical intervention, we have to try to restore local and temporal gradients of VEGF. That means we have to inject in the right place at the right time. And it is feasible, yes, it is feasible. Now we have instruments that allow us to deliver anti-VEGF exactly at the right place. And we are working on that. And the work of hemiartenet on receptors also is very important. Again, we don't know exactly the quantity of VEGF we need to restore the regular angiogenesis, and we can act blocking the VEGF directly, or even acting on VEGF receptors. In particular, if we are able to rescue the VEGF receptor 1, we can be able to restore the normal angiogenesis. And this is what also what Amy did years ago. The gene therapy that reduced the effect of the VEGF receptor 2 seems able to inhibit the pathological angiogenesis and allowing restoring the angiogenesis in the physiological way. And other possible intervention will be all these sites of the angiogenesis process. So a lot of work has to be done. And talking about future, and I hope to see you in Florence in December for the World ROP that we are organizing together with my friends here. Thank you so much, and sorry to be late.
No problem. Thank you so much, and that was very good insight.